Good evening, everyone. Welcome to the Oculus Inc. webcast, Practice Builder Roundtable, the Business of Dry Eye Management. Before we get started today, Oculus would like to say a few things. A few months back, Oculus started an informative and fun podcast called May I Interrupt. Each episode they talk on key topics in eye care from dry eye, myopia management, specialty lens fitting, and more. Head over to YouTube or Apple Podcasts to check it out. I also wanted to mention that Oculus is having our summer demo and refurbished unit sale, so now is the perfect time to reach out if you would like more information on any of our wide variety of products, including the Keratograph 5M. I hope you all enjoy the webcast tonight. Take it away, Dr. Barry Eiden.
Well, good evening, everybody, and welcome again to another in a series of webinars in the management of dry eye and ocular surface disease that's sponsored by Oculus. My name is Barry Eiden. It's been my pleasure to moderate a number of these webinars over the past month or so, and we've experienced a lot of changes in our practices and in our lives in general. I'm personally experiencing it just like each and every one of you, and we're going to make it through, and hopefully tonight will be a fun night. We're going to concentrate on some business aspects, some ways in which we could promote our practices. I think you're going to really learn a lot. In terms of my background, for those of you who don't know me, I'm President Medical Director of North Suburban Vision Consultants, which is a multi-specialty ODMD practice located in the Chicago suburbs. And my personal interest is in the emphasis of keratoconus, management of irregular corneas, ocular surface disease and dry eye, as well as glaucoma. Now, tonight we're going to concentrate, as I mentioned, on the business and practice management side of dry eye, with special attention given to the role that technology plays. We have a fantastic panel of eye care professionals who have successfully established dry eye specialties into their practice in their own unique ways. So right now, it's just my pleasure to introduce each of our panelists this evening. I'm going to start off with Dr. Tom Weshefsky, who is in Myrtle Beach, South Carolina.
Absolutely.
Right? Absolutely. So Tom is the founder of Carolina Forest Family Eye Care. He's a graduate of the Pennsylvania College of Optometry and began his career working with some of the original thought leaders in the area of specialty contact lenses and, in fact, in the orthokeratology space, such as Doctors Bob Morrison and Jim Day. And just on a side note, when I was a student, I went out, and you remember how Bob Morrison had his how-to conferences?
Absolutely.
Back in the day. So I went to Hershey, Pennsylvania, and I actually attended one of those. He was just an amazing individual for sure. Tom has a passion for myopia management and orthokeratology. He's also a fellow of the American Academy of Orthokeratology and Myopia Control, and he frequently lectures on this topic. And by the way, he's expanded his clinical interest into dry eye management, and that's why he's on our panel tonight, which is really going to give us a really interesting, different kind of perspective on how to bring dry eye management into your practice. Second, the handsome guy up on the, at least on mine, he's up on the top right, is Dr. Silani. He's in Beverly Hills, California, so he's a hoity-toity man, right? And we're really honored to have him. He is the Chief Clinical Director of Beverly Hills Optometry, and about 6 years ago, he started his Advanced Dry Eye Center. He's a second-generation eye care specialist, and he's devoted his practice to high-tech and focusing on office-based devices and methods to properly diagnose and treat patients with a variety of ocular conditions specific to ocular surface disease. And he's also a consultant. He speaks a lot about technology and for a variety of eye care companies, including J&J, Visionix, Luminous, Sight Sciences, Oculus, and Patient Pop, as well as others. Dr. Silani is very, very active in social media, and he's going to share a lot of his experiences with us. And he recently was on TV, actually, squeezing some meibomian glands, I believe. Isn't that true, Com?
That's correct.
That's right.
Yeah.
And our
the doctor show recently. Thank you
exactly.
for that introduction.
Wonderful. And our third participant, and very patiently waiting for a big introduction, is Jim Hale from beautiful Corvallis, Oregon, and I've been there a number of times, interestingly enough. You guys, is that where you have the state fair in Corvallis?
Just a little ways north of us in Salem, not too far
Oh,
off.
in Salem. Must have been on my way up there because, you know, I have to go out, and when I buy my cows, I usually go out to Oregon to do that. Anyway, Jim is an optometric physician practicing in a multi-location group practice in Oregon. He provides comprehensive vision and eye health care with a focus on medical eye health issues specifically, and he'll share tonight his interest in dry eye as well as in glaucoma, macular degeneration. So Dr. Hale also is a lecturer, and he's spoken all over the country on the topic of dry eye and has written numerous articles on this particular topic. So that's our introduction, and I think we should just jump right on into it, guys, if that's okay with you. All right, you guys ready?
Good. You bet.
Wonderful. So let's begin. It's kind of a little bit on the introductory side. We'll kind of get to know each other a bit better, and all of our audience getting to know you a bit better. So what I'd like you to do is to tell us a little bit about your practice in general, and of course more specifically towards its application towards ocular surface disease and dry eye management, and also tell us how you first got into this area. What were the steps that really got you involved and got you perhaps to the point where you are functioning today. So I'd like to start with Jim, if that's okay. Why don't you share with us?
Sure. Well, my primary practice is in Corvallis, Oregon, and like so many of my colleagues, I see the full scope of vision and eye health care issues. For many years, like many of you, I've been practicing in the dry eye arena, and honestly, I was pretty frustrated by the lack of results that I was getting in many cases. And so a few years ago, I decided to up my game and bring in some instruments that would help us really do a better job of diagnosing. What I didn't realize at the time is that it would kind of be a launching point into actually creating a dry eye clinic here in our practice. And so it's been amazingly successful, and I've been busier than ever trying to manage all of the dry eye care that we have here now. So it's been much more fun now that we're getting better results with better diagnostics.
Well, thanks a lot, Jim. And Kam, why don't you share with us your journey?
Certainly. So I'm local to LA, Beverly Hills area. Went to school just down the street from here. Family's been in eye care for over 50 years now. So I kind of grew up in the industry. I was a big fan of video games growing up. And so it just translated nicely into optometry with all the cool devices that we have, all the little gadgets from your OCT to OCULUS, and most recently the M22 and tear care and the treatment devices. So we also have a general clinic where we see patients for comprehensive exams, contact lens exams. But about 6 years ago, as you mentioned, we really started to dive deep into the dry eye ocular surface disease realm because just a frustration as a dry eye patient myself. I didn't see much improvement with pharmaceuticals and RX medications. And as these devices slowly started to build some steam behind them, we started to implement them kind of one device at a time, and just started to build a reputation as a go-to center for dry eyes in the area.
Thank you. That's great. Yeah, it sounds like a great journey, and it's wonderful that you come from, you know, kind of a pedigree of eye care with that in your family. I come from a pedigree of ladies' sportswear. That's what my father did. He made skirts. So, hey, there's different ways to get to the same point, right? Anyway, Tom, why don't you tell us about your journey a little bit?
So mine is kind of different. And after practicing in northern New Jersey in the New York metropolitan area for 20 years, in 2006, we moved to Myrtle Beach, sold both practices, moved here. Wasn't sure if I was going to retire or not. But after a month of not being in an office, I was climbing the walls, and you know, I missed it. I know that may sound crazy to some people, but I really missed it. I love what I do. I think we've got the greatest gig in the world. And so I opened up an office. The area we had moved into was growing rapidly. In fact, at the time, was the second fastest growing metro area in the country. It was all young families from the Northeast moving down south for better weather, a nicer quality of life, getting away from the taxes in the Northeast, and affordable housing. Well, that only lasted for a couple of years because then the crash came. Now, those were all young families with young children, and being an ortho-K myopia control guy, I thought that was a perfect place to build an ortho-K practice. Well, when the crash came, many of these people lost their jobs, they lost their homes, they moved back up north, and for 5 or 6 years, nothing happened here. There was zero growth. And as the economy began to recover, the only people who had money and could afford to move were baby boomers. They were all retirees. They were leaving the Northeast, they were coming here and retiring. And so suddenly my ortho-K practice seemed to dry up, and I had all these baby boomers coming in complaining of dry eye, and I realized there's a huge opportunity here. There's a tremendous unmet need, and that's what really got me started. And that was, I've treated dry eye and for years, but I guess like most people, I've been in practice long enough since before dry eye was even considered to be a condition, let alone a disease. It was just a thing, that people sort of mentioned. And treating it symptomatically by prescribing artificial tears really just wasn't getting anywhere. Seeing the results that were coming through with some of the modern technologies, I thought it was time to jump on board. And it went from dry eye being about 1% of my practice gross to about 21% of my practice gross in a matter of 6 months.
Phenomenal.
It's been huge for me.
Incredible.
That is incredible. That's a fantastic story. And honestly, I think we would all agree, any of us who delve deeply into contact lens care realize that if you don't also manage ocular surface disease, you're doomed to failure anyway. So your transition from a more ortho-K practice to a dry eye practice probably would have happened at your other practice if you didn't move and just kept working, because all your ortho-K patients would have gotten older, and even the younger ones using all their digital devices, right? So yeah, it's just natural. And I've always felt very strongly that if we don't understand the underlying diseases that we're managing with contact lenses, we're going to be doomed to failure long term anyway. So I think your experience really points that out. Before we move on to our next question, I just want to mention to our audience not to get too concerned if I, have a glass of wine and I'm sipping along the way, because that's kind of my modus operandi for doing any of these webinars. I can't do any of them without a little bit of wine in my hand. And luckily, Oculus had me do one of those, pardon the interruption or whatever it was, and myself and Stephanie Wu, who's also a level 2 sommelier. I'm not a level 2, I'm a level 1, by the way. We did that together, and it was just a hoot to do that along with Jason and Craig. So yeah, tune into those episodes. They are really, really good. They're fun and they're very lighthearted. Anyway, let's move on. So we all realize today that dry eye, as Tom alluded to, is far more than just, hey, here are 3 artificial tears, try them out, use the one that you like best, and I'll see you in a year. We've learned so much about it. We all are aware of TFOS, the Tear Film on Ocular Surface Society organization, as well as the report from TFOS being the DEWS 1 and DEWS 2. And one of the key elements in those reports is differential diagnosis. What is causing the dry eye? What is causing the ocular surface disease? There are different reasons why it happens. And tonight, I'd like you guys to share with us some of the ways in which you make that differential diagnosis. So in this particular case, I'm going to ask all 3 of you once again, how do you go about that initial screening for ocular surface disease? Do you use any specific questionnaires? Do you depend just on normal historical kinds of questions? And who performs these as well? Tell us those key methods and technologies you use for differential diagnosis of dry eye and ocular surface disease. I'll jump with Com as your first person to answer for us.
Thank you so much. So certainly speed questionnaire is something that we implement for all of our patients. Many years ago, we would hand select which patients would have to fill out a speed questionnaire, but we realized very quickly that Instead of just having high-risk patients fill it out, we just decided young, old, contact lens wearer or not to fill them out. So a lot of these patients you can capture, as you alluded to, Barry, your contact lens wearers, key women who wear eye makeup, patients with autoimmune conditions, patients with history of eye surgeries, and there are a number of different medications that can contribute. And we're all in front of screens now that we're either at home on webinars for CEs or for entertainment, or on Netflix and on our phones on social media, which I'm happy to get into later. So there's a lot of room for internal capture of these patients. We specifically use, so kind of timeline wise, when they get into the practice, the front desk will give them the intake form as well as a speed questionnaire. Then they'll be handed off to a medical assistant or a technician who will then go through their intake form with them. We have 3 advanced tests that we offer to those patients. An Optos photo upgrade with an extra copay, an Oculus or dry eye evaluation / allergy and sty upgrade, as well as an OCT upgrade. And the patient will initial off on that if they're interested. If they decide to sign off on all 3, then we have a little bit of a package deal for them. If we determine that they are a candidate, at that point, we'll perform the Oculus before we put any drops in. With the Oculus, we'll perform 4 tests that we prefer, which I'm happy to get into a little later, as well as my Beaumain gland evaluation, checking the function of their oil glands, and staining. Then the doctor will go over the results with them. They'll have a treatment counselor come in, a procedure counselor come in, go over things with them. So there's multiple touch points in our practice: front desk, technician, treatment counselor, and doctor. So they're kind of getting this repetition as we're connecting the dots for them.
Thank you. Thank you so much. Tom, you want to tell us your method?
Sure. Well, it really depends on why the patient's here. We use the keratograph to screen every single patient every time they come in for a comprehensive eye health exam, so their annual exam. We just automatically do 4 different screening tests using the keratograph to just look for potential issues. We'll do tear meniscus. We will do a redness score. We'll look at the lipid layer, and we'll look at the mammography. And if there's any issues there, we will reappoint them for a full, complete dry eye workup. If there's no issues, I congratulate them and say, great, you're doing just fine, and we'll check it again next year. And if things look a little different, we're going to have a very different conversation. The other kind of patients we see, if they have been referred in to us, then we just put them straight through the keratograph. We'll, of course, do a comprehensive history. We will do an OSDI. Their history would include things like lifestyle, sleep, any medications that they're taking, computer usage, and that's all I can think of at the moment.
It's okay.
Yeah, but just a complete history, and then we would run them through a full workup on the keratograph.
Great. So you actually use the keratograph as a screening tool routinely for virtually every patient at your practice?
Not virtually every patient, absolutely.
Literally
every patient. Now, yeah, it does add about 5 or 6 minutes to the exam process between the time to capture the images for the technician and then the time for me to review them chairside. But on the back end, we're catching so much dry eye disease that it's just incredible. And
yeah, that's amazing, Tom. That's our goal, is to get to that point where we're screening every patient with the Oculus. So kudos to you on that.
So I'm seeing a little difference between you two guys, and then I'll get Jim jumping in and tell us how he does it. So for Cam, you charge an out-of-pocket fee. You call it a copay. I call it an out-of-pocket fee because it's not covered by third party for the most part. We'll get into that as well. But Tom, am I hearing you correctly? Is it just part of your comprehensive eye exam?
Just part of the comprehensive eye exam. We don't charge an additional fee for it. Now,
for the screening portion.
For the screening portion, that is correct. If they come back for the full dry eye workup, there is a fee for that. And there is we charge an office visit, which will usually go to their major medical. but also we do a crystal tear report, and there's an additional fee for that as a non-covered service.
Okay, great. Jim, why don't you jump in? These guys have shared a lot of great info so far.
So we've been pretty tech-driven with our dry eye clinic, just out of necessity. It's just a little too busy to manage it ourselves. So the techs drive it. They take the patient back for a comprehensive eye exam and essentially do a verbal OSDI questionnaire, really digging in deeper as the patient has more symptoms that they describe. We're very fortunate that we've got several staff members that are really passionate about dry eye, so they enjoy diving into that topic. As all of you know, ocular surface disease, dry eye syndrome, it's a serious medical condition, and so we treat the Oculus keratograph as a medical test, much like you would do with glaucoma for a visual field. So when the staff identify some symptoms, oftentimes they'll do a zone quick test or some of the other preliminary tests. When I walk in the room, I'll go over those results with the patient, and I'll recommend that they come back for a dry eye evaluation in our dry eye clinic, along with an ocular evaluation with the keratograph. And that would be kind of, the medical model, as I said, similar to a visual field.
Okay, that's great. So I'm hearing that probably all of you, or maybe most of you, have your techs actually run the keratograph. Is that correct? Is that true for you, Tom, as well?
Absolutely. It's very highly tech driven. As I've progressed in my practice over the years, I do less and less, and the techs really do most of the data capture. I no longer capture data.
Right.
My job is not to capture data. My job is to interpret the data and prescribe for the patient.
So let me ask you guys, in your opinion, what are your really go-to key informative tests from the K5, from the keratograph on the ocular surface that you feel really are the most powerful? Cam, you want to start?
Absolutely. So from the doctor perspective, we do non-invasive tear breakup time, tear meniscus height, conjunctival redness, and meibography. From the patient perspective, we describe it as we'll check the anatomy of your oil glands, we'll check for inflammation or any red spots on the whites of your eyes, we'll check the tear volume, and we're going to check the consistency of your oil glands.
Jim?
Oily component of your tears, pardon me.
Sure. Jim, what do you think are your go-tos?
Yeah, so we think of this as both a diagnostic test, but also an educational tool. And so I find that tear meniscus measurement, where the patient can see the height of their own tear meniscus, is really valuable. I love showing patients SPK when it's there, because they understand the surface skin is breaking down. Oculus has a really amazing tear breakup time video that really does show a patient what happens when they blink and then open their eyes and those tears just drain away. So I really kind of focus in on the whole package with a special emphasis on those 3 measurements.
Great. Well, I think that's really, really critical. And what's very interesting is all of us, including us, all agree on those key tests. Those are the ones that are most important. But actually what they do is they target us to therapy, right? So we want to figure out where the problem is emanating from, and a lot of times it's multifactorial, obviously, but you want to see if the driving force is evaporative or aqueous deficient, and that really helps you go in that direction. And that's what's so wonderful, in my opinion, about the keratograph, in the fact that it really helps target your therapy through differential diagnosis, and I know you all agree with that. I think, Tom, you mentioned about the crystal tear report as an educational tool, which is an amazing thing. You all know Crystal Breimer, she does a lot of consulting for Oculus, and she and I have done a few things together, and I got to say that is one really powerful tool. Could you comment about that and how you use it?
Absolutely. I think that crystal tear report is really the key feature for the keratograph. I mean, there are a lot of instruments that'll capture data, and I believe the keratograph is the best single instrument to capture all of the data, but we can replicate that data with other different instruments. But what the keratograph is absolutely brilliant at is being able to clearly, concisely, and cogently lay all this out in such a way that I can not just tell the patient what's wrong with them, but I can show them, I can show and tell, I can demonstrate what is actually happening with their eyes. And when they see the redness score, or when they see the low tear meniscus height, or they see their meibography or their lipid layer, for the first time ever, they actually get it. They understand what's going on with their eyes. And the truth is, you were the first one that ever told them that. No one ever showed them that before, and that just blows them away. The ability to show them and demonstrate validates their symptoms, because a lot of times, they've seen doctors who've given them bottles of artificial tears, and really, historically, there was not a lot of clinical signs that matched the symptoms. So now we can see the clinical signs and validate their symptoms, and it's that aha moment to them, and it allows me to then no longer try and be a salesman and sell them on some potentially expensive out-of-pocket treatment. I can demonstrate why this would work, and they're asking me for the treatments, and I'm just an educator at that point.
Right. Well, it's a great segue into where I wanted to go next, and that is getting into the treatments section. So, Cam, if you would share with us how you go about creating, in essence, your own algorithm for managing ocular surface, and take us kind of through a quick, review of that, if you don't mind.
So I'll try to simplify it as much as possible, but each patient really is unique when they come into each and every one of our practices. Certainly, a majority of patients who have ocular surface disease or dry eye disease have MGD. As we know, 9 out of 10 of those patients have MGD. So our practice revolves around devices that treat that condition. So we carry, and not that other practitioners listening in need to have all these devices, but again, we just like to geek out. So we've done, articles and studies and consulting for companies, but the iLux, Tear Care, the LipiFlow, MibaFlow, the IPL, BluffX are some of the devices that we have in the practice. So if we're looking at their eyelids and we see anterior blepharitis, BluffX is usually my go-to. If we see biofilm along the eyelid margin, which the keratograph does some phenomenal photography, external photography, so we can show the before and afters. So just as Tom had mentioned, the crystal tear report is great for education and connecting the dots and gathering a baseline. And it's wonderful to be able to show them prior to treatment and post-treatment, figuring out, okay, how do you feel now when they fill out a speed questionnaire post-treatment, but also showing them their non-invasive tear breakup time has improved. Their meibography, for the most part, is irreversible. There may be some arguments against that with IPL and some other devices, but for the most part, there might be pseudo-regeneration that we're seeing in those patients that may have regression, and then we're seeing improvement in their oil glands. The OCULUS really drives us as far as, do they have staining on their cornea? And therefore, do we put a Procura on the eye after drops in steroids or things of that sort? Xiidra and Restasis, Aqua. Then if we see the gland function is not working properly, or there's any recession or loss, then we start to cue in towards the heat modalities, the thermal modalities. If we're seeing telangiectasia, inflammation on the lid margin or the ocular surface, then we start to cue in on things like IPL, specifically the M22 by Luminous, just because it gets rid of a lot of the earlier generation, the side effects from the earlier generation devices, such as scar and discoloration, hyperpigmentation or hypopigmentation. So it really has, the Oculus really drives us in that treatment process.
That's fantastic. Jim, your practice obviously is also highly dedicated to glaucoma management, which is one of my passions as well. And as we know, when we're managing glaucoma patients, there's a total algorithm in how we do things. And from point A to point Z along the way, knowing kind of where we're going. How do you apply that to ocular surface disease in your practice?
Yeah, well, Tom mentioned a moment ago the power of meibography, and that's such a huge component of what we manage for our dry eye patients. So when we can show them that they're losing meibomian glands, it makes it pretty easy to convince them to do the right thing and treat the meibomian gland dysfunction. So that's almost always a part of what we do. And then we add other treatments on to target specific areas of problem. So if there's a whole bunch of SBK plus 4 SBK, maybe we're looking at Procara. The whole range from simple warm compresses, massages, up to LipiFlow, Procara. It's completely unique to every patient. It's absolutely driven by what we see in the Oculus keratograph. And it's also absolutely driven by getting the patient to understand their condition so that they will sign off and agree to do what's important to keep the health of their eyes intact. So
Yeah,
I wouldn't say
that's
it's
great.
exactly it's not exactly a formula. It's very unique, as Cam mentioned.
Yeah, I mean, I think honestly, it's been a difficult topic for our profession or all eye care professions to come up with an agreed upon true algorithm for the practice. A number of years ago, I think it was maybe even 3 or 4 years now, we had a huge dry eye get together that was sponsored by Alcon, actually, because it's called the Dry Eye Summit. There were probably about 20 or 25 of us there. And if I tell you, after 2 days of hammering this stuff out, I felt like I was in the Israeli Knesset. Nobody could agree on a damn thing. So, it's still a problem, and I still find that challenging. All of us have our own sort of ways of doing things, and we're all successful in one way or the other. But I surely would like us as a profession to eventually come up to some sort of consensus in how to go from point A to point B. But we're getting closer.
I think the two study is pretty close to what we all agree on as far as where to start, but then modify that and move things around depending
Absolutely.
on the presentation.
And what's so wonderful, and again, thankfully we have the sponsorship of Oculus for our webinar tonight, but the truth of the matter is, regardless of the treatment modality, that instrument still becomes critical in our ability not only to diagnose, but to monitor for the effectiveness of our therapies, right? So that's really awesome that we can continue to use that. Talking about that, and this is a great topic, and I know a lot of attendees really have a concern about this. Obviously, this group, you're at the top of your game and you probably don't have as much trouble, but the average eye care practitioner may have difficulties when dealing with presenting, whether it's therapies or whether it's diagnostics that are not covered under managed care. And you have to have that conversation by saying, I feel that this is important. Here's what it does. And guess what? You have to pay for it. Whereas patients, and I look at it from the patient's perspective, dry eye ocular surface disease, medical condition, disease. Why the heck is this not covered by my insurance? I would love to get your perspective. Tom, you want to jump in first?
Sure. I'm an old guy like you. Sorry, Barry.
Yeah.
I remember the days of fee for service. And so we recall those days. I think younger docs who've just gotten out of school in the last 5 or 10 years, all they've ever known is managed care. And so I don't have quite as difficult time with it. Yeah, the fee discussions are always difficult to have, and sometimes it is a problem. But I really think that if you are educating those patients, and again, I'll go back to that crystal tear report, and you can really show them what's going on, and you tell them, look, this is where you are today. The consequences of not treating this meibomian gland disease is that more gland dropout over time. I understand that it may be difficult, but there is an out-of-pocket cost for this. Now, for those who cannot afford it, or just will not do it, well, we'll try and work within the parameters of what they have. I mean, a lot of what we do is kind of a wide-ranging approach in terms of procedures they do at home for little or no cost, nutraceuticals. If they can't do the in-office procedures, well, then we will make do with everything else that we can. I really try to avoid the use of drugs. Again, Cost is often an issue for those as well. And most patients would rather not do a drug. But
Yes.
it can be uncomfortable, but you just have to do it.
Yeah. So Jim and Kayam, you guys are like in very different areas, right? One guy's in Beverly Hills and one is in Oregon, where if they shut down, the lumber industry, you're kind of screwed, right? And I have a brother-in-law who lives in Eugene, so I'm very familiar with it. So you both have to present similar treatments, but you may have totally different populations. I'd love to get each of your perspectives on that. Whoever wants to jump in, go ahead.
I know that some of my colleagues in Oregon have talked about difficulty getting people to adopt treatments, and it just hasn't been an issue for us. We present the reason why, we show them what the problem is, the nature of it, and we tell them why it's important to treat that problem to protect the health of their eyes going forward. And we just haven't really had a challenge getting people to adopt the treatments that we recommend. Hasn't been an issue.
God bless
That's
you.
excellent.
Cam?
Yeah, Tom alluded to this earlier. Patient education is really the key. We are offering premium products and services, whether it's your premium daily contact lenses, your designer eyewear. This is really no different. We have a treatment counselor that will discuss fees with them. Sometimes if they're busy or they ask the doctor, we're upfront with them. We let them know. It's always important to highlight the benefits of something. If you only focus on the pricing, patients can give you pushback. But when you highlight, this is the condition, it's irreversible and chronic, early detection and intervention is key, and really highlight what the causes are and kind of guide them through that process, we get very little pushback from that perspective. We tell them we prefer the holistic approach. There are pharmaceuticals, they may have side effects, they're not always effective. The devices that we offer in the office, you'll have better compliance because the treatment is in our hands. And sometimes it's less expensive. I've had patients tell me that their Restasis is $300 to $500 a month, which is unbelievable. We do also offer package pricing as well that sometimes is helpful, whether it's for BluffX, Tear Care, and IPL. Those are the main ones that we provide packages for.
That's great. That's great. Well, so let's get back a little bit more to the K5, specifically to the keratograph. And, in all of the talks that I give about technology, and I give a lot of them, one of the key elements that I share is the importance of multifunctionality of instrumentation. All of us, our main office has 6,000 square feet, and I can't fit another instrument into it. We have no space. So the point is, if we have instruments that could do more than being a one-trick pony, to me, that's exceedingly valuable. And obviously, the keratograph is one of them. At our practice specifically, we use our keratograph pretty much as a dry eye instrument. We almost never use it as a Placido topographer, although it's a very good Placido topographer. Why? Because we have Pentacam. So, when I'm looking to measure the shape of the cornea, I'm going to use the Pentacam. We also incorporate aberrometry through the NIDEC OPD. So that also has Placido topography. However, there's a lot of practices that use the K5 as their primary topographer. As you guys mentioned before, it's a wonderful anterior segment imaging system, and there's other functions. I'd like to know if any of you use the K5 for anything beyond the ocular surface disease and dry eye diagnostics. Anybody use it for other reasons?
I've started to. I really, like you, this is my third topographer. I have the OPD3 with the aberrometer and the Placido disc. I also have another topographer that I've used to design wave custom RGP and ortho-K molds. And really the impetus to take in the keratograph 5M was specifically the dry eye module. But I have just recently started. I only have a couple of patients designing wave ortho-K molds on it, and initial results have been good so far, and so that's really promising. And of course, we use it for the anterior seg stuff. If there's a pinguecula, I can bill for the photo, or if they're a cone, we can bill for keratoconus.
Sure. Anybody else use it beyond dry eye?
We initially brought in the Visionics. I believe it's the VX120, and that is like a 7-1 system. It's like we call it an anterior segment analyzer. And one of the tests it performs is topography. But very recently, we've switched over to, and then maybe last year, we switched over to the keratographs topography, just because we can email those on. It gives us such accurate information as far as for LASIK candidates. We don't have the Pentacam yet, but the K5 does a fantastic job as far as topography. We can email those to our contact lens consultants when we're designing RGP or scleral lenses, as well as to our refractive surgeons when they're going in for LASIK.
Sure.
And our
Jim?
ideal model would be more of a hub and spoke model where our satellite practices could refer patients in for the keratograph. Looking forward, kind of down the road, as those dry eye practices grow, in the smaller practices, definitely the multi-uses for the instrument would be valuable. Here we have all sorts of toys and other instruments like you guys do, but in our satellite practices, definitely it has multiple uses, and that would make it more affordable once we grow those dry eye practices to the point that they could use it.
Yeah, that's great. Now, Tom, you alluded to the whole wave thing, and I do want to kind of get off on a quick little tangent on that. Many of you may or may not be aware that Oculus actually now owns Wave. So Wave has been this little, and Tom, you must have been one of those little wavers. It's a real niche of.
I drank
right?
the Kool-Aid years ago.
Drank the Kool-Aid, and I know a bunch of you guys, and you guys are awesome. I mean, these guys know how to design lenses like nobody's business, but the average practitioner still may be quite challenged to use that software. But I want to encourage everybody to realize that this merger between Wave and Oculus is huge, because Oculus is going to bring their technology as well as their understanding of the software to make Wave so much more accessible to so many more practitioners. And you know, I'm working along with Oculus in this regard, and I'm really excited because I think at its heart, Wave is probably the best designing of corneal GPs, even Ortho-K, out there. And now sclerals, as many of you know, using the CSP data off of the Pentacam, you're able to do things that are unbelievable in terms of customization. So it's just a matter of growing that area and making it more quote unquote user friendly, and taking it out of the, you know, the small niche practice, and really make it more accessible. So I'm really excited about that. So talking about technology, guys, and you guys are all into technology, and to me, technology is the reason I went into optometry. It's actually, I didn't know what healthcare profession I knew I want. My dad said, you have to be a doctor, because he didn't want me in ladies sportswear. That was very easy. So he said, you have to be a doctor. Okay, Dad, I'll be a doctor. What kind of doctor? I don't know. When I was an undergraduate, I visited dentists. I visited all kinds of people. I visited an OD near the university where I went to undergraduate, and he had the coolest toys. And I said, that's for me. So it's all grown from there. It's all about, you know, big toys for big boys, right? So we all like that sort of thing. However, each of us has to make decisions in owning and running a practice in terms of the best investment for instrumentation, diagnostic, and therapeutic. I'd love to hear your take on your calculation on how you decide what is valuable to take in technology, and how do you make that decision? Jim, can you start out with that?
Yeah, sure. So early on, when we were looking at the Oculus keratograph, you know, we knew approximately how many dry eye patients we see in a month, and it was pretty clear that it would pay for itself just based on the fees we would charge to do the procedure. I didn't fully account for how much it would actually grow the practice. We were pretty much at capacity at the time, so when you start successfully treating dry eye at a high level, those patients start coming in like you wouldn't believe. And so it actually overwhelmed our practice a little bit, and we had to scramble and make it staff driven in every way that we could. So it has exceeded our expectations by a long shot. I couldn't tell you the exact percentage growth of that segment, but I would say it's probably in the universe of what Tom described earlier.
That's great. Cam, how about you?
Yeah, we bring in devices that will enhance the patient care experience. I wrote an article for Review of Optometry, I believe about 3 years ago, on mybography and testing out the different devices, LipiScan, LipiView, the MyBox, and the K5M by Oculus. And we ultimately realized that the K5 added so much value to our practice and to our patients, especially with their comparison information. They'll take mybography and they'll take the patient's mybography and compare it against normative data from normal, mild, moderate, advanced, as well as redness injection. And what Jim alluded to earlier was really key when you're looking at the consistency of the oils for non-invasive tear breakup time. That becomes really powerful when the patient can see in live action how quickly their tear film is evaporating. I think that's huge. And we didn't turn, we chose that and haven't looked back.
Yeah, that's great. Let's move on to an exciting topic, I think, for all of us, and that is, how do we promote our practices through all of the things? We're doing such wonderful things. Apparently, Jim doesn't have this problem because people are like, knocking his door down. But many practices really need to expand and to grow, and they're not at capacity. And this obviously is a method by which they can really grow their practices. And I've always felt that the best way to do that to start out with is deal with the low-hanging fruit. The low-hanging fruit are all the patients you already have in your practice. That's the most efficient way to utilize any of your marketing dollars or your efforts to promote any new technologies at your practice. So, the king of marketing is up in the right corner there, Cam. So why don't you share with us initially, and I'm sure the rest of us can chime in as well, some of your success stories, and by the way, some of your failures, because all of us hear everybody lecture about how great they are and how successful they've been, like they've never made a mistake. Well, I've made so many mistakes, I can make a career out of it. So please, let's all be frank about our successes and maybe even a couple of our challenges and failures.
Of course, and I think the goal of the four of us here is to really help providers get to a point where they don't have to go through all the trial and error that we did,
right,
and then get from 0 to 60 much quicker than many of us did, and kind of jump over some of our failures. But as far as marketing is concerned, the easiest, least expensive is those patients who are walking into your door for a routine eye exam, hand them a speed questionnaire, and adds an extra 1 minute, a whopping 1 minute to their intake form and check-in process. But that speed questionnaire is really the starting point and can ignite such a wonderful dry center for you. As far as outside your patients that are coming through the doors, email campaigns are a fantastic way of letting patients know what new products and services that you offer. If you prefer mailers, that's fine as well, but you can save yourself a lot of money with envelopes and stamps by doing an email campaign. Patient Pop, Constant Contact, MailChimp, and there's so many out. Solution Reach. There's so many of them out there. Some of these services are included in your subscriptions. What else do we do? Just having pamphlets around the office is huge. If you have a TV, put videos up of different dry eye patient testimonials. That could be a fantastic way to promote yourself, whether it's in the office or on your website. An elegant, updated website is really key. If you can add telehealth appointments to your website or to your booking option, especially with COVID, that would be very helpful. We can very easily do a dry consult through telehealth. Doing the diagnostics and treatments is tricky. So, but that's one aspect to move forward. And we have a number of patients who travel from out of town. And so we could capture those patients if they're willing to drive 2-4 hours to see us or more, sometimes even a flight to see us. We can sometimes engage them early on with a telehealth visit, virtual visit, video visit, or after they've done their treatment, we can follow up with them and see if they're still compliant on their dry eye kit or their at-home omegas, compresses, etc., if necessary. What else do we do? Reaching out to your local ODs, MDs, let them know that you are a dry center and you've become an authority figure can be a great way. And reminding patients that signs precede symptoms. So what Tom is doing as far as screening every patient with the keratograph is huge, because sometimes these patients may score really well on their speed questionnaire, but you can pick up something, just like a patient can have a cavity, but they don't feel it. We can really do an amazing thing for them if we kind of take that first step and avoid them from ever getting to a point where they become symptomatic.
Yeah. Tom?
Well, I already told you how we do our internal marketing, and as Cam just said, yeah, we're just screening everybody, and that's really turned out to be huge. External marketing, you alluded to mistakes before. I've made them all with Ortho-K and myopia control, and trying to market that externally over the years. I have done print, I have done radio, I've done television, and I've lost my shirt doing that. So I'm a little gun shy with that external marketing. But our external marketing efforts, part of it Cam already mentioned, and that is having really engaging dry eye content on our website. But the thing that really surprised me more than anything else, it was letting the eye care community know that I now offer advanced services in dry eye treatment. And we've gotten a few referrals from our OD colleagues, but what has amazed me is the ophthalmology colleagues that have just really almost inundated us with referrals. And I'm talking about cataract surgeons, I'm talking about general ophthalmologists, cornea guys, I even have retinal specialists referring to us. And this is just something that they do not want to deal with. And especially the refractive surgeons, they want a pristine tear film before they touch that patient because it makes them look like a champ. You know, they're getting great results. They're not geared for this. They don't want to do this. And to me, that has been a huge surprise. I mean, people that wouldn't give me the time of day before now suddenly are sending me a lot of patients. It's been quite a a shock to me.
Yeah, I think that's a great point,
Okay.
Tom, in the fact that for your refractive surgical candidates, for your cataract, especially premium IOL patients, but another group is all your contact lens patients. So if you think about it, patient comes in, is interested in contact lenses. How can you go forward in contact lenses without assessing the ocular surface? You really should be doing a full dry eye workup on every potential contact lens patient, right? So that's something I think we overlook all the time.
I agree with that, but I've tried that, and that as a younger group, they tend to be resistant. They think that's an old person's disease, and
well, we know that's not true anymore.
Yeah, we know that's not true. We know we're seeing it in children, but they seem to be the more resistant. Maybe they're just more price sensitive. I don't know, but
well, it could also
have those patients who are contact lens dropouts, who are presbyopic patients as well, right? So we can put them in a DT1 lens, and DT1, acuvue 1-day clarity, all these lenses that have high DK values or great surface treatments should work well on a patient who has a really healthy, pristine ocular surface. If they're a dropout patient and they're in one of these premium lenses, it's got to be something with their ocular surface or their eyelids, right?
Right. And, you're right. They may be resistant, Tom, to telling them we need to do this separate ocular surface assessment. Well, just spin it. And the way we do it is we incorporate it in their contact lens diagnostic, which is also an out-of-pocket fee. And I don't care what you call it. It's part of the same thing. We're just getting that same information. So that's great. Yeah. And, I would just add in terms of because you went out into external marketing, which was my next area. And I've lost my shirt because we've been around about the same amount of time, right? So I've done a lot of that too. And I've realized also that by far the most effective is not paying for it. And that is getting PR. It's all about PR. And that can vary depending upon the interest of the world out there. Ortho-K, when we were first getting approval back, in 2001, 2002, I mean, I was on all kinds of TV shows. I was interviewed by newspapers, all this free PR, and it absolutely rocketed our practice, right? However, now there's, in terms of the media, not so much interest. Maybe it'll come back some point. So, getting PR, it's very helpful, but there has to be a lot of interest there as well. Jim, do you want to add anything into the practice management and marketing elements of what we're talking about?
Well, as I've said before, our staff are so heavily involved and they are passionate. We've got many kind of social groups here in our community that they've been a part of. They describe the treatments, they perform the tests, they can effectively go into these small group meetings and talk about dry eyes and really help people understand that there is an option if they don't feel so good. And so that's been very effective for us as well.
That's great. So I'm looking at the time and we're not quite done yet, but we're getting close to our last few minutes. So I think this is a great jumping off point for us to share our thoughts for those eye care practitioners who are first considering kind of establishing a serious and effective dry eye and ocular surface disease subspecialty practice. So I'd love to get the kind of like the words of wisdom from those who have been in the trenches and have been successful. What would you say would be the key elements that need to be put in place, and where should a practitioner start? So Tom, I'm going to let you start off with this one.
Well, if they're not already convinced that it's a huge issue and there is a huge demand out there, they can start, as Jim said earlier, by surveying their patients, do an OSDI or a speed test, and just really see if there's the need there. Once they're convinced that there is a need, then they have to realize, well, we have to think about the technologies we want to add into the practice. You have to sort of shop for that. You have to figure out, can you fit it in physically? Do you have room for this technology? If you have the room, who's going to run it? You, the technicians? Who's going to train them? Do you need to add staff? Once you do all that, you kind of have to figure, well, am I going to do ancillary products? Nutraceuticals, lid scrubs, who's going to carry that? You have to prepare all that stuff. And I really think the other things that you have to do is you have to look at your schedule, and you have to understand these people you can't shoehorn these appointments in between, contact lens evals. Like any specialty, they're going to require more time, and these are people who are going to require quite a bit of time, because they're going to tell you their life story about the pain that they've been through. It's one thing we haven't talked about tonight is pain. Optometry, we don't generally deal with pain. These are people who are in pain, and if you can solve their pain, they're going to be the path to your door. But the last thing I would do is, if you think you want to do this and you look at it and you evaluate it, and yeah, it's going to fit in your practice, get yourself trained. Go take a course. And when you do that, pick a course that not only goes into the clinical side, but also teaches the business side. And I can personally vouch for Crystal Breimer and her Dry Eye Institute. She's amazing. She does a wonderful job, and really will help you get your program implemented and up and running on fairly easily and fairly quickly.
It's great. You're speaking from years of experience and kind of the school of hard knocks, so we really appreciate it. Cam, you want to give practitioners your words of wisdom?
Yeah, definitely. Sometimes as docs, we can be skeptics. So first and foremost, I recommend having these companies and the reps come in and do a demo. It's complimentary, it's free, doesn't cost anything. Even prior to that, you're welcome to use simple things that you already have in your office, inexpensive, without technology, Schirmers, fluorescein staining, Lissaman green, using your finger to check the meibomian glands, use a transilluminator, put them up against the eyelid. Start there, see if you even have the patient base. I'd be surprised if you didn't have the patient base. Then you can kind of upgrade to different technologies, have one solid tool. That one of the big pitfalls that we made early on is we brought in treatments first, and then we brought in diagnostics. But once we brought in the diagnostic, the K5, the keratograph, our conversions went up, exponentially. It was fantastic. When the patient sees their own eyelids, that wow factor is there and it drives them. Those patients can become, even if those patients are skeptic, they can become your raving fans and your biggest supporters, especially the ones who are asymptomatic. The ones who come in and are symptomatic, just like Tom had mentioned, and they've seen 3, 4, 5 different practitioners. They're wearing sunglasses even outdoors. They can't work any longer. They can't spend more than 5 minutes on a computer. Those patients, when you treat them and get them back to functional, it's just so rewarding.
That's great. Thank you so much. Jim, words of wisdom.
Well, yeah, you'd mentioned earlier mistakes that we'd made, and one of my big mistakes with the K5M was bringing it in and not being truly prepared to implement it properly. It took me about 6 months of having a slow start to finally make it out to Crystal Breimer and the Dry Eye Institute and get some training on how to really utilize the instrument in clinic, and that's been huge for us. As far as advice for the practitioners out there, everything that Cam and Tom said is solid gold, but also my number one bit of advice would be to consider changing your mindset. If you're like me, for so many years, dry eye was frustrating. It took a long time in the exam room. The staff were grumbling when they saw a dry eye on the schedule. This is a treatable condition. It's a manageable condition. With proper diagnostic testing and education, you can make people better. And that's a big shift in mindset, at least it was for me. So that would be the one piece of advice I would give, is consider changing the way you think about dry eye conditions.
Thank you so much, guys. Well, guys, tonight was really an amazing experience for all of us who've attended this webinar and those of us who will be listening to it at another point in time. We've all become aware of the complexity of dry eye and ocular surface disease, the fact that it's so pervasive in the population and expanding everywhere. It's just growing like crazy because of, obviously, I think the influence of digital devices. And now that we're all living through the whole COVID world, everybody's spending half their time on digital devices. So I think our practices are actually going to see another, I hate to use the term, second wave of dry eye coming through. And we've emphasized the importance of understanding how to implement dry eye management into clinical practice. And our three panelists have done so in their practices in their own unique ways. Three totally different kinds of practices that have all been amazingly successful and create models that each of us can emulate. And I really want to thank you. I want to thank Dr. Silani, Dr. Hale, Dr. Weshefsky for sharing their expertise this evening. I also, of course, want to thank Oculus for sponsoring this webinar and all the other webinars we've done on ocular surface disease and other topics as well. You know, we're all living through very difficult times. We're challenged on all fronts, both personally, professionally, but with challenges, we all know, and everybody on this panel surely knows, challenge equals opportunity, right? So those of us who can adapt to these challenges and adapt to a changing world will not only survive, but we're going to thrive. So I want to thank all of you for being with us this evening. Please stay safe, stay connected. Good evening, and thank you, guys.
Thank you.
Thank you very much.
Good night.
Good night.